The protozoa that will be the topic of our discussion today are malaria, Leishmaniasis and Trypanosomiasis. Malaria and Leishmaniasis are two of the world's most important vector-borne parasitic diseases. According to WHO, Trypanosomiasis is found in 24 countries of the world and accounts for 97% of cases of sleeping sickness worldwide. Encompassing a complex group of disorders caused by these protozoa, we are going to discuss their life cycle, pathogenesis, epidemiology, clinical findings, treatment, and much more. In the introductory phase, we will study what species causes malaria. Malaria is caused by 4 plasmodia: Plasmodium vivax, Plasmodium ovale, Plasmodium malariae, and Plasmodium falciparum. P. vivax and P. falciparum are more common causes of malaria. Worldwide, malaria is one of the most common infectious diseases and a leading cause of death. The vector and definitive host for Plasmodia is the female Anopheles mosquito. You may be thinking how many steps the life cycle of Plasmodium comprises. Well, here are 2 phases in the life cycle: the sexual cycle, which occurs primarily in mosquitoes, and the sexual cycle, which occurs in humans, the intermediate hosts. The sexual cycle is called sporogony because sporozoites are produced, and the asexual cycle is called schizogony because schizonts are made. Following are the steps involved in the life cycle of Plasmodium in human beings. The life cycle in humans begins with the introduction of sporozoites into the blood from the saliva of the biting mosquito. The sporozoites are taken up by hepatocytes within 30 minutes. This exoerythrocytic phase consists of cell multiplication and differentiation into merozoites. Plasmodium vivax and Plasmodium ovale produce a latent form called hypnozoite in the liver. This form is the cause of relapses seen with vivax and ovale malaria. Then, as the cycle progresses, merozoites are released from the liver cells and infect red blood cells. During the erythrocytic phase, the organism differentiates into a ring-shaped trophozoite. The ring form grows into an ameboid form and then differentiates into a schizont filled with merozoites. After release, the merozoites infect other erythrocytes. This cycle in the red blood cell repeats at regular intervals typical for each species. Associated with the life cycle interval are the typical symptoms that are often experienced by the patient at this stage. This includes chills. Fever and sweating are the typical symptoms seen in patients with malaria. Now, let us move towards the sexual cycle of the Plasmodium. The sexual cycle begins in the human red blood cells when some merozoites develop into male and others into female gametocytes. The gametocyte-containing red blood cells are ingested by the female Anopheles mosquito and within her gut produce a female macrogamete and 8 sperm-like male microgametes. After fertilization, the diploid zygote differentiates into a motile eukinete that burrows into the gut wall, where it grows into an oocyst within which many haploid sporozoites are produced. The sporozoites are released and migrate to the salivary glands, ready to complete the cycle when the mosquito takes her next blood meal. A very important feature of Plasmodium falciparum is chloroquine resistance. Chloroquine-resistant strains now predominate in most areas of the world where malaria is endemic. Chloroquine resistance is mediated by a mutation in the gene encoding the chloroquine transporter in the cell membrane of the organism. We will now go through the pathogenesis of malaria. Most of the pathologic findings of malaria result from the destruction of red blood cells. Red cells are destroyed both by the release of the merozoites and by the action of the spleen. They either sequester the infected red cells or lyse them. Malaria caused by Plasmodium falciparum, it is more severe, characterized by infection of far more red cells than the other malarial species, and by occlusion of the capillaries with aggregates of parasitized red cells. This leads to life-threatening hemorrhage and necrosis. Furthermore, extensive hemolysis and kidney damage occur, with resulting hemoglobinuria. The dark color of the patient's urine has given rise to the term blackwater fever. The hemoglobinuria can lead to acute renal failure. The timing of the fever cycle is 72 hours for Plasmodium malariae and 48 hours for the other Plasmodia. Disease caused by Plasmodium malariae is called quartan malaria because it recurs every fourth day, whereas malaria caused by the other Plasmodia is called tertian malaria because it recurs every third day. Tertian malaria is subdivided into malignant malaria, caused by Plasmodium falciparum, and benign malaria, caused by Plasmodium vivax and Plasmodium ovale. Plasmodium falciparum causes a high level of parasitemia because it can infect red cells of all ages. In contrast, P. vivax infects only reticulocytes and Plasmodium malariae infects only mature red cells. Therefore, they produce much lower levels of parasites in the blood. Individuals with sickle cell traits, heterozygotes, are protected against malaria because their red cells have too little ATP activity and cannot produce sufficient energy to support the growth of the parasite. People with homozygous sickle cell anemia are also protected but rarely live long enough to obtain many benefits. The receptor for P. vivax is the Duffy blood group antigen. People who are homozygous recessive for the genes that encode this protein are resistant to infection by vivax. People with glucose 6-phosphate dehydrogenase deficiency are also protected against the severe effects of falciparum malaria. G6PD deficiency is an X-linked hemoglobinopathy found in high frequency in tropical areas where malaria is endemic. Both male and female carriers of the mutated gene are protected against malaria. Let us move ahead toward the incidence or causes of the spreading of disease. Malaria is transmitted primarily by mosquito bites, but transmission across the placenta, in blood transfusions, and by intravenous drug use also occurs. Partial immunity, based on humoral antibodies that block merozoites from invading the red cells, occurs in infected individuals. A low level of parasitemia and low-grade symptoms result. This condition is known as premunition. In contrast, a non-immune person, such as a first-time traveler to an area where falciparum malaria is endemic, is at risk of severe, life-threatening disease. More than 200 million people worldwide have malaria, and more than 1 million deaths occurs each year. It occurs primarily in tropical and subtropical areas. People who have lived or traveled in areas where malaria occurs should seek medical attention for febrile illnesses up to 3 years after leaving the malarious area. What are the clinical findings of the patient with malaria? Malaria presents with abrupt onset of fever and chills, accompanied by headache, myalgias, and arthralgias, about 2 weeks after the mosquito bite. Fever may be continuous early in the disease. The typical periodic cycle does not develop for several days after onset. An enlarged spleen is seen in most patients, and enlarged liver occurs in roughly 1/3. Anemia is prominent. The fever spike, which can reach 41 degrees Celsius, is frequently accompanied by shaking chills, nausea, vomiting, and abdominal pain. The fever is followed by drenching sweats. Patients usually feel well between the febrile episodes. Untreated malaria caused by falciparum is potentially life-threatening because of the extensive brain resulting from cerebral malaria and kidney damage. Malaria caused by the other 3 Plasmodia is usually self-limited, with a low mortality rate. However, relapses of P. vivax and P. ovale malaria can occur up to several years after the initial illness because of hypnozoites latent in the liver. It is very important to know the diagnostic criteria of the disease. Diagnosis rests on microscopic examination of blood, using both thick and thin gene-sustained smears. The thick smear is used to screen for the presence of organisms, and the thin smear is used for species identification. It is important to identify the species because the treatment of different species can differ. Ring-shaped trophozoites can be seen within infected red blood cells. The gametocytes of falciparum are crescent-shaped or banana-shaped, whereas those of the other plasmodia are spherical. If blood smears do not reveal the diagnosis, then a polymerase chain reaction-based test for Plasmodium nucleic acids or an enzyme-linked immunosorbent assay test for a protein specific for P. falciparum can be useful. Though the treatment of malaria is complicated, but following measures can be taken. The main criteria used for choosing specific drugs are the severity of the disease and whether the organism is resistant to chloroquine. Chloroquine resistance is determined by the geographical location where the infection was acquired rather than by laboratory testing. Chloroquine is the drug of choice for the treatment of uncomplicated malaria caused by non-falciparum species in areas without chloroquine resistance. Chloroquine kills the merozoites, thereby reducing the parasitemia, but does not affect the hypnozoites of Plasmodium vivax and Plasmodium ovale in the liver. These are killed by primaquine, which must be used to prevent relapses. Primaquine may induce severe hemolysis in those with G6PD deficiency, so testing for this enzyme should be done before the drug is given. Primaquine should not be given if the patient is severely G6PD deficient. One approach is to wait to see whether symptoms recur and then treat with chloroquine. Uncomplicated, chloroquine-resistant Plasmodium falciparum infection is treated with either Cortum or Malarone. In severe complicated cases, intravenous administration of either artesunate or quinidine is used. The artemisinin, such as artesunate or artemether, are widely used in combination with other antimalarial drugs. The artemisinin are inexpensive and have few side effects, and most plasmodia have not developed resistance to these drugs. However, resistance to artesunate has emerged in some strains of P. falciparum in Southeast Asia only. Lastly, the prevention of malaria is important to prevent its occurrence. Chemoprophylaxis of malaria for people who are thinking of traveling to areas with chloroquine-resistant Plasmodium falciparum consists of mefloquine or doxycycline in a fixed dose can be used. Chloroquine should be used in areas where Plasmodium falciparum is sensitive to that drug. Travelers to areas where the other three plasmodia are found should take chloroquine starting 2 weeks before arrival in the endemic area and continuing for 6 weeks after departure. This should be followed by a 2-week course of primaquine if the exposure was high. Primaquine will kill the hypnozoites of Plasmodium vivax and Plasmodium ovale. Other preventive measures include the use of mosquito netting, window screens, protective clothing, and insect repellents. The mosquitoes feed from dusk to dawn, so protection is particularly important during the night. Communal preventive measures are directed against reducing the mosquito population. Many insecticide sprays, such as DDT, are no longer effective because the mosquitoes have developed resistance. Drainage of stagnant water in swamps and ditches reduces the breeding areas. There is no vaccine for malaria. That is all about malaria. Stay tuned to sqadia.com to learn about other protozoal organisms.